Welcome to Pathology Central Key Concepts. This video will focus on nephritic and nephrotic syndromes, as well as a small detour through mechanisms of glomerular injury, because if you don't understand that, you won't understand nephritic and nephrotic syndrome. So our objectives will be to begin with a review of the organization and structure of the glomerulus to give us a starting point. Next, we'll discuss the mechanisms of glomerular injury, compare and contrast nephritic and nephrotic syndrome, and finish up by analyzing the pathophysiology of a classic example of each syndrome. Now, if you're like me as a medical student, through whichever source you use, the internet, a book, an outline, you have written down these are the things to memorize for each of these syndromes. For nephritic syndrome, you should know it causes hematuria, mild to moderate proteinuria, azotemia, which is defined as increased BUN and creatinine, and hypertension. And for nephrotic syndrome, you will memorize massive proteinuria, hypoalbuminemia with a plasma albumin of less than 3 grams per deciliter, generalized edema, and hyperlipidemia and lipiduria. And that's what you're memorize. But this video will help you understand why you see this in these particular syndromes. And we're going to begin by looking at the glomerulus. So this is very stylized glomerulus. There's a single glomerular tuft right here. But this is going to help us understand where we're coming from. So here we are in our glomerulus. We have our afferent arteriole bringing in blood, and here are our capillaries here within the glomerulus. And then we have the efferent arteriole taking blood away. We have our parietal epithelium, which is lining Bowman's space. This is the urinary space here. And this is where urine will travel out of the kidney. Now, in addition to our parietal epithelium, we have our visceral epithelium, which is composed of podocytes with these little foot processes coming down here. Now, we're going to look at a enlarged image of this here. So here you can see, as you'll recall, the capillaries in the glomerulus are fenestrated, which means they have little windows. So you can see those here. We have our basement membrane, and then we have our foot processes. And the foot processes are going to have these protein moieties that span across here, which is going to determine the size of the protein molecules that can enter the urinary space. And here you can see a beautiful electron micrograph with the fenestrated endothelium on top. There's a fenestra or window, our basement membrane, and then our foot processes of the podocyte here. So looking at this, you can see that damage to any of these components is going to break down your glomerular filtration barrier. If you were to just knock this out completely, you'd have free exchange of blood into the urinary space, and that would cause hematuria. So let's talk for a moment about the mechanisms of glomerular injury. How are we going to injure that particular area? So there are two primary means of glomerular injury. We can have injury due to deposition of circulating antigen-antibody complexes, and we can have injury due to antibodies reacting in situ within the glomerulus. So in the first instance, we can have these circulating antigen-antibody complexes to endogenous antigens, which we see in lupus or in IgA nephropathy, or in exogenous antigens, so infectious, for example, post-streptococcal. If we look at immunofluorescence, what we're going to see is a granular pattern, and this is due to the localized antigen and antibody deposition. It's somewhat stochastic, so it's going to accumulate in some areas. It will appear granular. On electron microscopy, we will see either subendothelial humps, which we can see in lupus, or subepithelial, as in acute proliferative glomerulonephritis. Something to keep in mind is we can also get mesangial deposits, which we'll see in IgA nephropathy. The other way that we can have injury due to antibodies reacting in situ within the glomerulus. So antibodies can react with an intrinsic antigen, so a component of the glomerular basement membrane, and this is classically seen in Goodpasture syndrome, or extrinsic antigens that are planted in the glomerulus. And if they are planted in the glomerulus, it's again going to have this granular appearance. So we can see that again with systemic lupus erythematosus. So lupus can cause granular depositions due to either of these two mechanisms. The only really good example we have of linear immunofluorescent deposition is going to be good pasture. So if you see that on a board exam or as part of what you're doing as a pathologist in the future, you will know that that is due to good pasture syndrome. And again, what we'll see here will be on electron microscopy will be subepithelial humps or deposits. They actually begin in the subendothelial area and then they transition to be subepithelial. And what will happen here is we'll get basement membrane thickening. So let's look at an image that sort of puts this together. So we have here our deposition of circulating immune complexes. So they're floating around in the blood. They arrive in the glomerulus, and as they come through, they get trapped in the subendothelial deposit here, as in lupus, or here underneath the parietal epithelium, here in the between the foot processes, which we can see in acute proliferative glomerulonephritis. Now, another possibility is in situ immune complex formation, and this can be again due to antibodies that are reacting with planted or endogenous antigen. This is again going to give us our granular appearance. And our one linear example of this will be the deposition of anti-glomerular basement membrane antibodies in good pasture. It's going to line up here with that linear immunofluorescence. Now, what's going to happen is when you have antibodies that are trapped in the glomerulus, this is going to stimulate the immune system to begin attack, right? This is what the immune system does when there are antibodies that are attached. And so we're going to get complement deposition, we're going to bring in inflammatory cells, and this is going to cause the damage that the inflammation causes is going to cause increased glomerular permeability, which will lead to proteinuria, and this complement activation and leukocyte recruitment will lead to that inflammatory injury. So how does this relate to nephritic syndrome? So let's look here at our four classes that we want to look at: hematuria, proteinuria, azotemia, and hypertension. So nephritic syndrome is defined as having glomerular inflammation. So nephritis comes from itis, meaning inflammation, and it's typically autoimmune. So it's not going to be through some sort of virus or bacteria that's attacking your glomerulus. And what will initially happen is we're going to get disruption of the glomerular filtration barrier, and this is going to lead to our mild to moderate proteinuria. Now, there are a variety of different ways we can disrupt the glomerular filtration barrier. So inflammatory damage to endothelial cells, immune complex deposition, as we just discussed, disruption of the glomerular basement membrane as in anti-GBM disease. Once we have this happening, we can also get, because we're going to get inflammation, injury to the glomerular capillary walls. And what will happen here is this is going to lead us to our hematuria. So the inflammation injures the glomerular capillary walls. We're going to see what we can call cola-colored urine, sort of dark brown. And if we look at a urinalysis, we'll see dysmorphic red cells and casts. Now, because of this injury to the capillary walls, we're going to get capillary hemodynamic changes, which are going to cause a decrease in glomerular filtration rate, so decreased GFR. Once you get decreased GFR, this leads to oliguria and fluid retention. These two are going to lead to the hypertension that you see in nephritic syndrome. And finally, with decreased GFR, you're going to get an increase in your BUN and creatinine, leading you to your azotemia. So you can see how this progression leads us to the variety of manifestations of nephritic syndrome. Now, prototypical diseases are listed here. We're going to focus on the first one here, acute proliferative, also known as post-infectious glomerulonephritis. So, what we call acute proliferative post-infectious glomerulonephritis is actually a cluster of diseases, and you can get it due to exogenous or endogenous antigens. So exogenous antigens may be due to infection like streptococcus, or endogenous as we see in lupus. And as the name tells you, acute proliferative, we're going to get a diffuse proliferation of cells. So we're going to have proliferation of endothelial and mesangial cells, as well as infiltrating leukocytes, both neutrophils and monocytes. So when we look at an image of this, which I'll show you in the next slide, it's going to look very cellular. Now, acute proliferative glomerulonephritis is caused by immune complex deposition, and as I mentioned, often secondary to streptococcus. I'm going to focus here on what we see in children because it's more common in children. You can also see this in adults. So about 1 to 4 weeks after infection, a child will present typically with mild proteinuria, periorbital edema, and mild to moderate hypertension. And they may have that, as I mentioned, cola-colored urine. This is due to granular immune complements that deposit in the glomeruli. When they deposit in the glomeruli, with the little antibody tail sticking out, we're now going to get complement that's going to be activated. And if you were to do a lab test for serum complement, levels would be decreased because it's being globbed up in your glomeruli. What will happen next is we're going to get subendothelial deposits, which will then shift to the subepithelial space where the antigen-antibody complexes will lodge. So this is what we'll see morphologically. Look how hypercellular this glomerulus is. I'm going to compare it here to a normal glomerulus. This is a PAS stain, but it does help you see, first of all, the lack of cellularity in comparison, and also you can see how the capillary loops here are patent. They're easy to visualize. In contrast, what we see here is you can't really identify the capillary loops. Everything is just full of cells. This is immunofluorescence for C3, and it's going to give you that classic granular appearance. And the reason is we're getting these deposits here, subepithelial. So here's our podocyte with its little foot processes, and this is the classic finding. So with all of this inflammation, we are getting disruption of the glomerular filtration barrier. Inflammatory damage to the endothelial cells is going to lead to that hematuria, and because of this damage, we get capillary hemodynamic changes, decreased GFR, oliguria, fluid retention leads to our hypertension, and our increased BUN and creatinine. All right, so that's it for nephritic syndrome. Let's now turn to nephrotic syndrome, which has a different appearance altogether. Instead of that mild to moderate proteinuria, we have massive proteinuria, and because of that, we're going to be losing a lot of albumin. So our plasma albumin is going to be less than 3 grams per deciliter. This is going to result in some changes that are going to lead to generalized edema and hyperlipidemia as well as lipiduria. So let's talk about why we see this. So nephrotic syndrome, in contrast to what we saw for nephritic syndrome, is due specifically to derangement in the glomerular capillary walls. And this is going to vastly increase the permeability to plasma proteins. This will lead to our heavy proteinuria, and since we're losing all of this protein, a lot of it is albumin, so hypoalbuminemia. Because we have lost so much serum protein, we're going to have a decrease in our intravascular oncotic pressure, and we're going to get severe edema as fluid leaks out. One of the other consequences of a decrease in oncotic pressure is that it is going to inspire the synthesis and decrease the metabolism of lipoproteins in the liver. What this is going to lead to is our hyperlipidemia and our lipiduria. These are our prototypical diseases: membranous nephropathy, minimal change disease, and FSGS, and we're going to focus on membranous nephropathy for this talk. Okay, so it is the most common cause of nephrotic syndrome in non-diabetic adults, but it has an insidious onset due to the slow rate of complex deposition and damage to the foot processes. So it's not going to have an acute onset. However, when it does come on, you're going to have marked proteinuria, hypoalbuminemia, and severe hyperlipidemia. So it's a chronic immune complex mediated disease, and about 75% of cases are primary to some renal autoantigen, and most of those are going to be phospholipase A2 receptor, or PLA2R. About 25% are secondary, so lupus, drugs, or malignancies. So if you have a patient who is diagnosed with membranous nephropathy, you need to figure out why they have this disease. You need to be able to rule out the drugs so that you can discontinue a medication if that's the cause. You don't want to miss an occult malignancy, and we can do tests to see if we have PLA2R. Because of these depositions, we're going to get diffuse thickening of the glomerular capillary wall because of these subepithelial immunoglobulin deposits. And we don't know the exact mechanism, but it's thought that the C5b C9 membrane attack complex is going to activate the glomerular epithelial and endothelial cells to begin pumping out proteases and oxidants, leading to capillary wall injury, therefore onto protein leakage. So here is the morphology. what you can see here is that we don't have a particularly hypercellular glomerulus. This is a silver stain, and you can see how the basement membrane is thickened. It's quite thick around these capillary loops. These are wire loop lesions. And if we look at immunofluorescence, you can see this granular staining, again telling you that you have your antigen antibody deposition. Now, what's causing this? Here is a schematic where we can see our mesangium here, our fenestrated endothelium, our podocyte with foot processes that are in the process of being effaced. Why are they being effaced? Because we have these subepithelial deposits which are bringing in an inflammatory response. And we can see this very nicely here on the electron microscopy. Look how thickened the basement membrane is, and here are all of these deposits here within that. So the etiology will be that the C5b9 membrane attack complex is going to damage the glomerular capillary walls, leading to the increased permeability of plasma proteins. This heavy proteinuria leads to hypoalbuminemia, decreased intravascular oncotic pressure, which will have two effects. It's going to cause edema, and it's going to increase synthesis, decrease metabolism of your lipoproteins, leading to your lipidemia and your lipiduria. Okay, so this has been a quick trip through nephritic and nephrotic syndromes. I hope they have given you the tools to understand why you see these two different syndromes based on the pathophysiology. Here are a few questions to help you confirm that and what you've learned in the last 15 minutes or so. I hope you found this useful. As always, always glad to hear from you, and thank you very much for your time and attention.